Hello, everyone. Good morning, and thank you for attending our Grand Round lecture. This Grand Round is part of the Kongdong Lectureship series. Let me provide you with a brief information about Kongdong Lectureship. In 2010, Natalie and Jack Kongdon established the Natalie and Jack Kongdon Visiting Scholar in Cardiology, which enables the VCU Health Pauley Heart Center to attract a number of talented cardiologists and physicians. After his service in the Army, Jack helped build the family trucking business of Old Dominion Freight Line and Old Dominion Truck Leasing. Jack was a proud supporter of the Massey Cancer Center and the Pauley Heart Center. Jack and Natalie passed away about 10 years ago. They had 3 children, and their son, John, continues to support the Pauley Heart Center as a donor and advisory board member. I'm pleased to introduce you to our speaker, Dr. Jonathan Kim. Dr. Kim is an associate professor of medicine and founding director of sports cardiology in the Division of Cardiology at Emory University School of Medicine, and additionally holds an adjunct professorship in the School of Applied Physiology at the Georgia Institute of Technology. He received his Bachelor of Science at Emory and was a Fulbright scholar before attending Vanderbilt Medical School. He completed his residency in internal medicine and pediatrics at the Massachusetts General Hospital and cardiology fellowship at Emory. He was the chief fellow from 2013 to 14. In addition to his clinical role, Dr. Kim conducts NIH-funded current R01 grant sports cardiology research at Emory. He is the team cardiologist for the Atlanta Falcons, Braves, Hawks, and Dream, and for sports medicine at Emory and Georgia Tech. Dr. Kim is a member of the NBA Cardiac Advisory Committee and NFL Cardiovascular Task Force. He is the co-medical director for the AJC Peachtree Road Race in Atlanta, Georgia. Dr. Kim is the current chair for the American College of Cardiologists Sports and Exercise Cardiology Council. We are grateful for Dr. Kim's expertise on sports cardiology and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Round Conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloudcme.com or contact Shannon Winston. I will now turn it over to Dr. Jonathan Kim. Dr. Kim.
Well, thank you so much for that introduction. And of course, thank you for the kind invitation to present here this morning. And we're going to talk about sports cardiology. You can see by the title, Changing Landscapes to Consider for the General Cardiologist. So as you can imagine, given the depth of the field now, there's only so much one can cover. But we'll try to cover some bread and butter topics, but really try to highlight where the field has shifted dramatically over the last several years in terms of consideration of sports eligibility for athletes with heart disease, and the shift away from line in the sand disqualifications to much more of a shared decision-making approach. So you already heard my disclosures, so we can move on to the objectives for this talk. And as mentioned, we're going to talk about athletes with heart disease, try to focus in on some bread and butter topics that all of us as cardiologists will run into in the clinical setting. So we'll talk about risks and etiologies, focusing on the incidence of sudden cardiac death. What are some of the common etiologies to think about whenever you have both athletes who succumb to sudden cardiac arrest or suffer sudden cardiac arrest, but even the symptomatic athlete and the differential diagnosis. As mentioned, we're going to focus on this shift out with the old, which is a focus on medical paternalism, this line in the sand approach whenever you encounter an athlete with heart disease who wants to consider to play sports, and in with the new. We're all embracing shared decision-making in all facets of clinical cardiology, and sports cardiology is no different. That being said, we'll talk about some of the challenges that remain. Shared decision-making with athletes, the lack of qualitative-based science to really enforce best practices. So this is a work in progress, and we'll highlight some of the challenges that exist. And then a little bit of a shift away from these topics, but certainly a bread and butter topic where there is debate. And what I'm talking about is the pre-participation evaluation of athletes, this being the consideration of screening ECGs. That's always a topic that's of high interest among all of us in cardiology and sports medicine, but also have to talk about where there is no debate. And of course, that is the focus on the emergency action plan, immediate CPR, access to AEDs, and the shift of emphasis on legislative advocacy within this space has really been exciting over the last year. So we'll talk about that to conclude the talk. But I want to just kind of begin with the growth of sports cardiology, a field that truly has exploded over the last 10 years, probably has existed for at least around 20 years or so, but it's really been in the last 10 years. And so I highlight this and parallel this with some high-level state-of-the-art reviews published in JACC since 2014 that have showed the evolution of the field, talking about sports cardiology, where the sports cardiologist is a key component of the athlete healthcare team. But in 2017, there was a paper talking about the core curriculum, meaning if you practice sports cardiology, what are some of the important topics that you have to understand and develop expertise within. A more recent review, again, focusing on exercise-induced cardiac remodeling, but beginning to talk about shared decision-making. We appreciate guidelines specifically within the space. Up front here, I'm showing you the international criteria. So many of you are aware that when you interpret the athletic ECG, it is different compared to the interpretation of the ECG of somebody in the general public. And that's important, particularly as you think about screening. It's not the easiest, and a lot of individuals will kind of freak out whenever they see an athlete ECG and think it's abnormal when it's really normal. We have guidelines as it pertains to sports eligibility, which we're going to talk about as well. So a lot of growth, and certainly now if you encounter an athlete, hopefully you have somebody that has the expertise that you can rely on for referrals, because many complex issues can arise now. But let's begin with risk etiologies, and we'll talk about upfront. When you talk about the incidence of sudden cardiac death in athletes, the question that always arises, how common is this? And the answer is it's hard to actually pinpoint a specific number because there are certainly limitations in the literature that exists. It's not the easiest question to answer. Number one, you got to ask the question, well, what type of study design are you looking at? Obviously, retrospective study designs looking at this are clearly limited. You have to ask the question, have you identified all the right cases that exist out there? And of course, you have to look at what's your denominator, what population are you looking at? And even a simple question, are you looking at sudden cardiac arrest alone? Or are you looking at sudden cardiac arrest combined with sudden cardiac death? Clearly, if you're just focusing on the athletes who don't survive, you may be limited in terms of exactly identifying the problem. Also, how are you defining sudden cardiac death? People think about sudden cardiac death during exertion or 1 hour after, but what about an athlete who potentially suffers sudden cardiac arrest during their sleep? Clearly, that's limiting a bigger scope of the issue, which is just what is the incidence overall in the population. So I tend to rely a lot on the NCAA data. I find these data to be some of the most robust. Why? Number one, these are prospective data. Number two, it's a well-defined population. And number three, addressing some of the limitations I just mentioned, how they've specifically defined cases. So it's not just a review of catastrophic insurance claims, which is limited, but it's relying on review of media reports, which also is limited, but even more so registry data. And they say they utilize a couple different robust registries to identify these cases. Data were published in 2015 that were just updated at the end of last year, looking at the incidence of sudden cardiac death over the last 20 years. And these were cases that could occur anytime throughout the day. So not just limiting it to cases occurring during exercise. And what they found, looking at the last 20 years, was affirming that the most common medical cause of death, remember the most common cause of death is actually death due to accidents, but the most common medical cause of death was, in fact, sudden cardiac death, with an incidence of about 1 in 64,000 athlete years. And interestingly enough, that's actually declined. It was about 1 in 53,000 in 2015, but also affirming some trends. We know that men are at higher risk, and this observation that self-identified Black athletes are at higher risk compared to white athletes as well. We're going to get back to that as well. And even the concern that there may be differential risk by sport type, where compared to the 10-year data, again, affirming that men's basketball appears to be the highest risk sport, also, or followed by American football as well as soccer. What about some of these trends? Again, for unexplained reasons, certainly there's some hypotheses out there, but men are much higher at risk, almost 4 times the risk of sudden cardiac death compared to women within this age group. But also the affirmation of differential risk by self-identified race. So these are a few of the studies, the 20-year data not in this slide, but also that could be included, where it appears that self-identified Black athletes are at higher risk compared to white athletes. And here's where we have to raise the caution flag. We have to be very careful about how we interpret this specific observation, remembering that, of course, race is a socio-political construct. It's not a biological construct. So we have to avoid jumping down that rabbit hole and assuming that this could be due to some inherent biological difference as it pertains to risk. This risk certainly mirrors what we see in the general population. And certainly in the general population, we know that the differential risk of sudden cardiac death are actually due to many of the environmental stressors that we know exist, particularly experiences with structural racism, experiences with discrimination. And these important topics have not been well vetted within this population. But at least in my opinion, it's likely that a lot of these environmental stressors play a role. And this is an important theme that you hear about through this talk. Again, as we look to the future, trying to avoid some of the pitfalls that we have previously believed when we've seen some of these type statistics. Well, let's talk about etiologies now. Epidemiology, again, seeing that overall cases are rare, although exact incidence type figures are difficult to really present. And also, I should note, because of the fact that we don't have a mandatory reporting system here in the United States. But when we talk about etiologies, and one could even think about symptomatic athletes as well, but we'll just focus on when you have an athlete who suffers sudden cardiac arrest. The etiology is very much age dependent, and certainly this is affirmed. So for the younger athlete, which we'll define as an athlete, competitive athlete less than the age of 35, who suffers sudden cardiac arrest, the evaluation will focus on causes within one of these 3 bids. Is it a structural abnormality? These, of course, are your genetic cardiomyopathies, such as HCM, arrhythmogenic cardiomyopathy, et cetera. Is it a primary electrical problem, one of your genetic arrhythmia syndromes, such as WPW or long QT, or is it an acquired abnormality? And of course, the most common cause here you would think about would be myocarditis. And if we reflect back just over the last few years throughout the worst of the COVID-19 pandemic, of course, myocarditis generated a significant amount of attention as it pertains to etiologies of SCA or symptomatic athletes during the pandemic. So whenever we have one of these cases of SCA in a young athlete, it does require a very comprehensive and careful evaluation, trying to identify one of these potential causes. And that's, of course, generally led by a sports cardiologist, but usually involving other subspecialists as well. Now, for the master's age athlete, and a master's athlete is defined as an athlete older than 35, the etiology is much simpler. And in fact, if you go through causes number 1 through 10, perhaps, before you start thinking about some of these other causes, it's generally going to fall in the category of ischemic heart disease. And this could be precipitation of ACS and acute plaque rupture, but we know if you look at cases of marathon runners who have suffered sudden cardiac arrest, we published these data more than a decade ago now. Actually, stable coronary disease and demand ischemia is an important cause of SCA within this population as well during exercise, but still falling within the category of ischemic heart disease. Now, let's talk a little bit about some of these etiologies in a little bit more detail. So provide a little bit of some of these key teaching points within the cases of young athletes who suffer SCA. Particularly for some of the fellows who may be watching. So one of the causes of sudden cardiac arrest in young athletes that's important to consider are congenital coronary anomalies. And the most common would be your anomalous origin, either the anomalous or an anomalous left coronary origin off the right sinus or vice versa, where we know the anomalous left coronary origin off the right sinus with an interarterial course is clearly the more higher risk phenotype. So I know I'm starting to get a little bit older here, but maybe some people recognize this gentleman here. I won't ask because unfortunately we're virtual, but that's Pistol Pete Maravich. Perhaps there's always kind of the famous athlete who's the poster child of a certain diagnosis, and he unfortunately died from a congenital coronary anomaly. He didn't have an anomalous origin, anomalous aortic origin of the coronary artery. He actually had a very rare type. He had a single RCA that was found at autopsy. And there's actually a little bit of controversy if that was really the underlying etiology of his death. But nonetheless, he's kind of considered the poster child. As mentioned, the more common anomalies that we worry about are the anomalous origins off of the opposite sinus. The reason why this is important is that you have to have a high index of suspicion. And this is also important when we think about screening, because screening, as probably many of you are aware, by history and physical is not really possible. And certainly even by ECG and even echo is limited. You have to have an experienced sonographer who's trying to identify one of the coronary origins, and that's not generally performed, at least in the adult echo labs. The gold standard is going to be MRCT. Obviously, we're not going to be doing screening CTs on all athletes. So, of course, the critical point here is if you're involved with a more intensive screening program of competitive athletes that involves screening EKGs, this is always the elephant in the room diagnosis. You're not really going to be adequate in terms of identifying these. And that's why congenital coronary anomalies are always going to be one of the top 1 to 3 diagnoses in terms of registries of sudden cardiac death cases of athletes. Here's just a picture of what we talked about for the trainees. At the bottom, this is normal coronary anatomy. You've got your right sinus, left sinus. Of course, here we see the left main origin, the right origin. And up top, following the cursor, this is the higher risk phenotype where we see the anomalous left coronary origin off the right sinus with the interarterial course. Now, one question that sometimes arises is what's the mechanism of sudden death? It's probably not as simple as thinking of scissoring between the pulmonary artery trunk and the aorta, the ascending aorta. It's actually not quite understood. There's a lot of differential hypothesized mechanisms out there, but clearly this is the higher risk phenotype. When you have an anomalous right origin off the left sinus with the interarterial course, that's a little bit more controversial. And sometimes that can be picked up incidentally in terms of how to risk stratify, how to think about risk of sudden death. And unfortunately, that's a little bit beyond the scope of this talk, so we'll have to leave that there. But I do want to highlight this study here. This was published during kind of after the COVID pandemic. There's a registry, which we'll talk about at the end of Grand Rounds, called ORCA, called Outcomes Registry for Cardiac Conditions in Athletes. And ORCA is really designed to follow outcomes of athletes diagnosed with heart conditions who choose to continue to play after shared decision making. But initially, it kind of kicked off the ground because of screening athletes after COVID. Just for full disclosure, I'm one of the co-Is within ORCA, but the registry is led at Mass General and University of Washington. But this study was just showing that of all these screening echoes, and these were athletes who obviously were rolling through echo labs where theoretically there was a sports cardiologist or somebody who was caring for athletes. And you can see that the coronary origins were not reported on these echo reports well over 80%. And one of the teaching points that I have, certainly if you are caring for athletes, and I have this discussion with our sonographers, is if any of my patients roll through an echo lab, I don't care if it's a screening echo, if it's for whatever reason, I want to have reporting of those coronary origins. Of course, generally I'm reading these echoes, but I want to ensure that they're trying to identify these. And you can see here on the short axis, you can see the left origin, the right origin on the bottom here. Actually, the right origin is generally better viewed on the peristernal long axis. Sometimes it can be challenging on the short axis. But the point is you need to be looking for these if you're taking care of athletes. The second condition is arrhythmogenic cardiomyopathy. So this is not one of the more common genetic cardiomyopathies. So why do I talk about this? This is the only genetic cardiomyopathy where data suggests that ongoing intensive exercise actually worsens outcomes. Now, it's important to note that a lot of the data that we rely on in terms of this concept comes from single center data from Hopkins. We know that Hopkins actually has probably the most rigorous and robust ACM registry in the entire world, but nonetheless, it's still single center. But what they've shown is that those individuals with arrhythmogenic cardiomyopathy who continue to engage in high intensive endurance exercise had earlier expression of heart failure as well as earlier expression of an arrhythmic phenotype. Now, it's also important to note that this is primarily the PKP2 variant. And so it's a little bit more controversial if you have non-PKP2. But if you do have PKP2 identified in an athlete, that is probably the one time where you really are going to counsel away from ongoing intensive exercise, and it probably doesn't as much fall into a shared decision-making paradigm. For the non-PKP2, it is, I think, more controversial, and certainly there may be a little bit more of a space for SDM. All right, so that's a nice segue then into one of the key topics that I wanted to get into is you have an athlete with heart disease, whether they survived SCA or they're just symptomatic, and they want to continue to play sports. So how do we go through the process? And we begin with certainly relying on previous guidelines. And these are the old Bethesda Conference proceedings, which were initially published in 1985, published in or updated in 1994, 2005, and then in 2015, actually transition to an AHA-ACC scientific statement. Now, it's important to note, however, that many of these guidelines were certainly primarily all expert consensus-based and fell much in the line of a conservative paradigm. Now, in 2015, with the scientific statement, there began to be a shift towards a little bit more embracing the concept of shared decision making, though I will emphasize that shared decision making itself, that term was not anywhere written explicitly in the document. Also, it was just beginning. So this paragraph here comes from the Task Force on Genetic Cardiomyopathy. If I were just to summarize, the authors write that there still needs to be conservative and prudent recommendations applied homogeneously across the broad HCM disease spectrum. And this could unavoidably result in the disqualification of some athletes who are probably at low risk and unlikely to ever experience sudden death. Now, I don't know about you, but that certainly does not sound like shared decision making at all to me. And we've shifted there. So where does this shift come from? Well, just to begin with, when we think about this concept of athletes who want to return to play, a lot of this dates back to this very famous case, Nick Knapp versus Northwestern. So Nick Knapp was an elite basketball player, got a scholarship to play at Northwestern. Unfortunately, he went through an event where he was diagnosed with the condition, had to have a defibrillator placed prior to enrollment. Upon enrollment, through his physicals, he was ultimately disqualified because of that. So Mr. Knapp ultimately sued for his right to play. But in the end, this was actually turned down by the U.S. Court of Appeals, stating that it was within Northwestern's right, based on consensus at that time with documents, that for them to disqualify Mr. Knapp, and this was not in violation of the Rehabilitation Act. They did note, though, that not all universities or organizations could potentially interpret the case the same way. So what are some of the downsides, however, again, in terms of thinking of disqualification? Well, it begins with some of the obvious. We know that if you're not allowing exercise, engagement in sport, there's a lot of these downsides, not just in terms of the development of bread and butter cardiac risk, but psychologically. And all of these benefits of engaging in sport. But it really gets down to the ethics. It is just unethical to completely remove an individual from these decisions and not hearing their voice at all. And it's wrong to think that athletes can't voice their own opinions, that they're going to only want to play sports, and that they just can't think through these decisions in an appropriate way. That is clearly not been actually shown in the data, and certainly not my own experience. Now, I'll tell you, I actually had the opportunity to meet Mr. Knapp. This was at AHA in 2023, so almost a year ago now. And that's him in the blue tie here. The gentleman in the blue blazer is another athlete with a cardiac condition, Omar Carter. And I have to say, I was struck by Nick's story. He really went through what it felt like to be completely excluded from this conversation. And it's just a reminder again about how that was just the wrong approach. It's very actually quite moving. It's not just the ethics. There's data now. So when you look at long QT syndrome, athletes with ICDs, conditions where it used to be felt that you couldn't play sports with these conditions, actually athletes who returned to play, their outcomes were much better when they were followed in experienced hands. And uncertainty was still, with many of these conditions that we consider to be quote unquote too high risk, there's uncertainty. And of course, as we all know, when there's clinical uncertainty, that's actually where shared decision making is clearly indicated. And now we have even more data. So if we talk about hypertrophic cardiomyopathy, many of you are aware of data that have come out over the last year, beginning with the Live HCM data, multi-center led by Rachel Lampert at Yale University. And here they looked at individuals, almost 700 with HCM, who continue to engage in vigorous exercise compared to individuals with the HCM who were only engaged in lower levels of physical activity, perhaps more sedentary. And the primary outcome was composite, looking at sudden cardiac arrest, unexplained syncope, shock. And as you can see by these Kaplan-Meier curves, they're almost superimposed. There's absolutely no difference in terms of outcome. Now, there are some limitations, of course, not representative of all patients. These are individuals all cared for at high-level HCM centers. They define vigorous activity based on AHA physical activity guidelines. There were not as many true competitive athletes within the registry, and so the generalizability not firmly established, but clearly showing again then how overall that the risk in these individuals who were continuing to engage in high levels of physical activity were not as high as one would think. This was combined with this study, which is a little bit more appropriate to the population of competitive athletes. So this was really a case series from numerous high-level sports cardiology institutions looking at high-level athletes. These were professional athletes or high-level NCAA D1 athletes who had genetic heart conditions who, after shared decision-making, chose to return to play. And they followed for outcomes over 200 athlete years of follow-up, a total of 7 years. And the primary outcome measure was what they called a breakthrough cardiac event, which could have been a shock, an SCA event, etc. And the first thing to acknowledge up front is that these were not cherry-picked low-risk individuals, because certainly we can all agree that there are some athletes with genetic or individuals overall with genetic heart conditions who may be lower risk versus high risk. As you can see, a third already had an ICD implant for whatever reason, and almost 10% had a prior history of sudden cardiac arrest. So again, these were not low-risk individuals. Overall, as you can see in table 3, there were 3 individuals. So this is a 4% breakthrough cardiac event rate, one of which was an ICD shock. There were no deaths, and only one of these cases was actually during exercise. So not a prohibitive level of risk, again, when these individuals were followed in experienced hands. So I had the opportunity to write the editorial to this piece and highlighted a few other additional important points. Within this cohort of about 74 athletes, 3/4 were initially disqualified. So when we talk about shared decision-making, clearly not as common as we would hope, as these were individuals who sought second opinions after being initially disqualified. Critically to emphasize, while we say we need to embrace shared decision-making, this is not a rubber stamp. Doesn't mean that if anybody comes to see me in Atlanta, hey, you want to play sports? Doesn't matter what your phenotype is, we're going to clear you to play. No, we cannot abrogate our duty to call high risk when we see high risk, whenever there's too much risk involved. Within this study, the limitation of generalizability. How should we think about this with athletes who come from more underserved neighborhoods? Again, the issue of disparity is critically important in sports cardiology. Remember, these were pro athletes. These were high-level D1 athletes. Generally, these athletes come with resources at their fingertips. And then potentially institutional bias. These are athletes who are all cared for at high-level centers. But the bottom line overall, we can see here again that this idea of being too conservative is probably not appropriate. And there is a space when you look at the risks that we see, and for all the reasons that I mentioned, to focus in on shared decision-making. Ultimately, we need more outcomes data, and that's where we'll talk about ORCA again as we follow more athletes with heart disease. So as mentioned, the landscape has changed. This is a figure from one of the reviews we wrote from our council a couple years ago, where we talk about the pillars of shared decision-making in sports cardiology. This is really no different than when you think about SDM and really all facets of clinical cardiology. But of course, you have to have the knowledge within the space that you're working in. You have to have humility. You need to bring in other experts, bring in additional opinions or other colleagues and subspecialties in cardiology to assist. But critically important, we have to ensure that we respect the patient's voice. Days of just telling the athlete what to do are gone. That's inappropriate. We have to work as a team, of course, working with other colleagues, but also that means bringing in the athlete and their family and have that appropriate communication. So when we talk about the guidelines, as you can see, the most recent document that we have, this is the 2015 document. You can already point out some pitfalls that I mentioned. SDM not as emphasized as it should. And even in terms of the data that we have now, kind of conflicts with what was presented in 2015. And if you're a sports cardiologist, generally, you're not really following the guidelines to a T all the way across the board. And that's a problem because many cardiologists out there who don't have the luxury of having a nearby sports cardiologist are going to rely on this. And that could be why a lot of athletes are still being disqualified. Well, the good news for those who probably aren't aware of this document's actually being updated. So I'm honored to be the chair of this process, but we are in the process of putting together an updated scientific statement to follow up 2015. And we're actually well within this process. It is written, it's actually essentially done with peer review. And our hope is that this document's actually going to be out by the end of the year. So we're near the end of the process. And I think that's really exciting for all of us in cardiology because it is really going to move the needle. Seeing the emphasis on shared decision making. I don't think I'm violating embargo to clearly know. I think it's pretty obvious if you've been paying attention to this talk that that's going to be emphasized. And there's just going to be a lot of wholesale changes across the board. Well, that leads then to the next question, though, as we emphasize shared decision making. How do you do it? And I mentioned in my objectives up front, this is where we lack some qualitative science. I do think this was written by a colleague of mine, Aaron Baggish, friend and colleague, just outlining some basic tenets. I would agree with these 8 pillars here. You have to make sure you've got the right diagnosis, of course. You have to risk stratify that diagnosis. You have to provide the education to the athlete and then incorporate the athlete's preferences and values. And that's where the SDM process really kicks in. And then bring in other stakeholders, implement the decision, and then, of course, set up your follow-up plan, which should include annual surveillance. It's not a one and done. You should be engaging in repeat shared decision making at least on an annual basis. Sometimes athletes will change their mind. Sometimes things will change clinically, which can potentially increase that risk. That's critically important. This is another slide from a friend and colleague, Matt Martinez, who emphasized some of these same pillars. I like this because it puts the team physician in the center. So this is something called the team physician model, where the head team physician for the university or organization you're working for is the primary gatekeeper, coordinating between all the stakeholders, the sports cardiologist, the athlete, their family, to implement the decision, which could potentially include return to play. It could also include a modified exercise plan. Maybe it is best to shift away from competitive exercise. This is a piece that we wrote a couple years ago. I wrote this with a colleague at Emory, Neil Dickert, who's an expert in the space of bioethics. We don't have the best qualitative science to guide the process at present. So best practices is out there. You're going to find shared decision-making probably a lot of different flavors. And that can be an issue for a lot of different reasons. You can have biases that come into play, both from the physician standpoint, but then from the athlete standpoint. Perhaps there's a disconnect between the perception of risk between the physician and the athlete. In the end, whenever you have this, unfortunately, you can veer away from what's desired, which is truly an athlete-centered decision. Ensure everyone's on the same page. So I believe that there really should be an emphasis on qualitative science moving forward. We need to define best practices so an athlete who's engaging with shared decision making at an expert center can expect the same quality as an athlete who may be away from an expert center and working with a cardiologist in the community type setting. And in the end, we have outcomes that are really uniform across the board. So that, I think, should be a focus as we look to the future. Well, let's shift to the last part of the talk. I want to ensure that we have a lot of time for discussion and question. And that is, as mentioned, where there is debate, but also where there is no debate. But let's talk about this concept of ECG screening. I think that's an important topic to get in. All general cardiologists, sports medicine, general practitioners are interested in this topic and probably engaged to some degree with these pre-participation evaluations. So this is the AHA 14-point history and physical. This is the bread and butter. This is where everything begins as part of the PPE. I would say actually that if you have a symptomatic athlete, this is a bit of a cheat sheet. This is exactly what I'm going to be talking about when the athlete comes in, a focus on exertional symptoms. If it's a symptomatic athlete, let's really talk about when the symptoms are occurring. Of course, during screening, you want to get at, has any of this occurred? That's really important. One of the key symptoms to focus in on is unheralded syncope, chest tightness during exercise. Certainly, there's more red flag symptoms that may warrant holding the athlete during the evaluation. Perhaps there may be an opportunity where you want to get some testing done, but you're not as concerned and maybe you're going to allow training. So again, there's some of the nuances in care there. The critical focus here is family history. If there's one thing that you could ask, if you're not allowed anything else, you want to get at what is the family history of unexplained sudden death, but clearly working through some of these genetic syndromes. One thing, again, just another nice teaching point is if you do this, don't fly through it. If you fly through these conditions, what you'll find is an athlete that chuckles at you because they probably have heard of none of this, or an athlete that's just trying to get in and out of there. Sometimes if you focus in on hypertrophic cardiomyopathy, hey, this is whenever somebody in the family has a heart that they were told is too thick, or something like that, layman's terms. Also, when you're describing palpitations, because they definitely have never heard of what a palpitation is, you may find actually uncovering clues that are important. I actually add questions. I'll ask about pacemakers or defibrillators in young people. So there's some things that can be inclusive within the family history that aren't part of the 14 point. And then the physical exam, of course, clearly looking for stigmata of connective tissue disease, heart murmurs suggestive of provocable LV outflow tract obstruction, et cetera. That's all important part of the H&P. The H&P has horrible sensitivity to detect these conditions. 10, 15%. I mean, something really unacceptable. So why does everything begin with this? To me, it's all about that interaction between a healthcare provider and an athlete. Sometimes, if it's an athlete who's coming from an underserved arena, this is a point in time where you can bring that individual in front of a medical practitioner, potentially to discover underlying hypertension, things that may not be sudden death risk, but are clearly going to be important in terms of the overall medical care of that athlete. And of course, you may discover an important part of the family history. You may discover an important symptom. But we all have to recognize that the H&P from the screening standpoint is not that good. It's just a really essential part of medical care. So that's where the ECG comes into play. So hopefully everybody looks at this ECG and recognize the delta wave, Wolff-Parkinson-White pattern. So in screening ECG in an asymptomatic athlete is going to pick this up. Obviously, if they're asymptomatic, you're going to miss this. And this is, of course, long QT, a very long corrected QT interval. And so these are the conditions potentially discovering in an asymptomatic individual, HCM as well. The sensitivity is far more increased when you include a screening ECG, upwards of 94%. So why is it then that we're just not saying, you know what? Why, my goodness, why aren't we doing EKGs on just everyone? Well, this again is where there's important considerations. I will say up front, this is the international ECG. I mentioned the guidelines that we talked about in 2017. If you're not familiar with this document, it's a nice thing to kind of print out, have in your pocket if you see athletes, because there are certain findings that would actually be considered abnormal in an older individual who's not an athlete. Even some of these borderline findings here, which may be normal in isolation in athletes. So it's critically important that you're familiar with this if you are screening athletes, because if you are not, you are definitely going to overdiagnose abnormalities and have a much higher false positive burden, which is not what we want whenever we're screening athletes. And that's really what, again, leads into the challenges here, which is, yes, the sensitivity is much higher, but if you're in inexperienced hands, you can actually go down rabbit holes, as we all know, that we don't want to go down. Inappropriate diagnoses, inappropriate restriction from sport, and inappropriate, potentially even disqualifications that we want to avoid. So it has to be done in expert hands. And then the resources as well, just as critical, right? Because once you have that abnormal ECG, you better know what to do with it. And if you have not thought that through and you have an athlete who doesn't have health insurance, well, now you've really opened up a problem for that individual. These are the things that have to be thought through. So the equity and outcomes has to be a critical part of whenever you're implementing screening programs. And the reason why is we still don't have data that have clearly established that a screening ECG actually saves lives. There's one study which was published in Italy in JAMA, which showed a tremendous amount of mortality benefit. That's the only one. And there were some limitations in that study. But if you look at data from the US, data from Israel, other studies, we clearly haven't shown that the ECG saves lives. And so again, that's the challenge, that's the controversy. So when we think about screening and some of the challenges to think of, particularly in the United States, of course, as mentioned, it's about resources, it's about cost in our system, legal issues, even considering who's going to be reading all the ECGs. And then, of course, the things that I already emphasized, the concern of false positives, and then the efficacy part. the mortality benefit. So all of this is why we likely will never have this as a mandated across the board in the US. You need to do screening ECGs. So probably everybody's wondering, well, what's your opinion? So my opinion on this is screening ECGs, implementing this in your screening program is certainly reasonable because we know we're going to detect more. That's beyond, or that's been affirmed by data. And that is ultimately going to potentially improve the care of that athlete down the road. So while we don't have the data to suggest that identifying that asymptomatic wolf maybe say quote unquote saving their life, clearly knowing having that athlete understand they have that is going to tailor their healthcare towards knowing that as they look forward to the rest of their life. So it is reasonable, but there's critically two caveats. Number one, expertise. You need to have the right people doing the ECG. If somebody just rolls into town and says, hey, let's just start screening ECGs, and we do have that out there, and it's all for the right reasons. They're trying to save lives of athletes. But if that hasn't been carefully thought through about how you're implementing that program, I can promise you the negative side of that's probably going to come to a head more. I cannot tell you how many athletes have been referred to my practice who have been disqualified for months. Parents are pulling their hair out, the athlete's stressed out, and nothing was wrong with them. Maybe the ECG was just inappropriately interpreted just to begin with. And I would submit that those are not the outcomes that we want. And those don't get talked about enough. So you have to have the right expertise, and then that leads into the resources. You have to make sure that you have equitable resources for the athletes who have these screening ECGs. If all of that is in place, then certainly, clearly, we know that the screening EKG does carry some benefit downstream, as I've already mentioned. So it's a complex topic. That's how I think it through. And on the flip side, if you don't have the right expertise, if you don't know that everybody's going to be able to get that echo or the MRI downstream, then I'm not so sure that a screening ECG program is actually going to be beneficial to the population that you're screening. So that leads into a second topic, which is the ECG criteria up front. And this will tie into a lot of what we talked about already, which is equity in terms of care of athletes. So when we look at the efficacy of the international criteria, the false positive rate is about 1%. It's improved substantially over the years. But there's a differential false positive risk between self-identified Black and white athletes. So these are data from the UK here, where they looked at over 11,000 soccer players, and they looked at false positives between British, white, and Black soccer players. The overall false positive rate, as expected, around 1%. But look here. So in this figure here, we're looking at ECG criteria across the evolution over time, from the ESC criteria to Seattle, and you see international here. You can obviously see the improvement in false positive rates, but you'll still note that it's almost double for self-identified Black athletes. Now, there were some limitations with this study as well. This was essentially all male. And even though this was a study looking at differences by race, you'll note that almost 90%, over 90% were still white. Despite the fact that they had an overall initial robust number. So I think this gets back into, again, the equitable outcomes as well. When you utilize these criteria, you're preferentially going to identify abnormals in self-identified Black athletes. So as mentioned, if you are within a neighborhood that's marginalized or underserved, you're going to self-select out more minorities who have abnormal ECGs. And so again, that just leads into, are we really doing the right thing for the population? And this is something that doesn't get talked about enough. And I'll remind everyone that these are just UK soccer players, and this is a research study. My experience clinically is that we do see a lot more false positives in self-identified Black athletes. If you look at the NBA, abnormal ECGs utilizing the international criteria for Black athletes is upwards of 16%. So it is definitely not this 3.6 even across the board. So with the sudden cardiac arrest event of Bronny James, I guess the date was around the summer of 2023 or so, there was this narrative that came out because of the higher risk of Black athletes that I've already talked about, that maybe we should do targeted screening of higher risk athletes, which include Black athletes. And based on what I've just said, you can imagine that a lot of us within the space push back on that for all the reasons that I mentioned. We don't understand what explains this higher risk of sudden death in Black athletes. Clearly, the appreciation of social determinants of health may be an important role, and ECG screening is not going to detect that. And because of the false positive differential that exists, this notion that we should just target screen Black athletes clearly is fraught with problems and could potentially actually introduce more harm within this population. So this was a statement that we put forth in August, as you can see. This was on acc.org. Again, just acknowledging that what we need to do is better understand what explains this differential risk rather than just assuming, again, that race is a marker of biology and embracing these race-based medical practices, which we should be actually pushing back against. This is an editorial that we wrote. I wrote this along with several members, a part of our council and others, where we talk about this, a call for action and inclusion, appreciating race as a social construct, not biologic, focusing on social determinants of health and future outcomes research. I should update this slide. We actually updated this with a much larger piece on racial disparities in sports cardiology. For those who aren't aware of this, we published this in JAMA Cardiology in July of this year. So please read it because we really talk about this notion of how we used to think about race in sports cardiology, how we should be thinking about this, where the gaps are as we look to the future. It's a really, I think, important piece as we think about future directions in the field. So let's talk about where there is no debate now. And this is the emergency action plan. And just a reminder of some events. So what does this look like? So this is Keontae Johnson in 2020 on national TV. Clearly the face plant, everybody saw this. Damar, watch him get up after the hit. Similarly, the stagger and the immediate drop. This is what sudden cardiac arrest in a young athlete looks like. We all have to recognize that. And if people didn't know the Keontae Johnson story, obviously Damar we know about. We can even include Bronny James. Of course, that was not on videotape, but all of those young men survived because the trainers involved knew what this looked like and they engaged in that emergency action plan. So where there is no debate, we know this saves lives. These are the core principles. It begins with what I just showed. What does it look like? You got to know what it looks like. You, of course, have to focus in on knowing CPR and AED training. That's more for the coaches, of course, within the athletic training side. Immediate CPR, immediate access to AED, things that don't get talked about enough. The plan's got to be written, distributed, and then it has to be rehearsed and reviewed regularly, at least on an annual basis. These are the core elements of an effective EAP if you're taking care of competitive athletes. And over the last year, really because of Damar and his emphasis on this, there's been such attention on this space. For us in sports cardiology, for everyone in general cardiology, of course, focusing on CPR and access to AEDs, that's nothing new to us. So why is it all of a sudden the public and politicians care about this? It's because of Damar, and he really deserves a ton of credit for this. Now, the Access to AEDs Act was not necessarily Damar, although he supported this. This kind of all came out at the same time last year. This would provide grants across the board for schools to purchase AEDs, to get access to AEDs, to develop these emergency response plans. And then in the springtime last year, as a response to Damar's event, the NFL initiated the Smart Heart Sports Coalition. This is a coalition focused on legislative advocacy. So there's such momentum in this space right now. So what is Smart Hearts focused on? These are the three key tenets. We need to have laws in all states that ensure all high schools have EAPs present. We need to ensure that there's an AED within 1 to 3 minutes of all high school athletic venues. And we need to ensure that all coaches are trained in both CPR and AEDs. So as you look at this, I'm sure you're thinking, this is a no-brainer, right? I bet most states have this. And before Smart Hearts, shockingly, only 7 states in the US had these 3 laws present. Now with Smart Hearts, that number's more than doubled. I think it's around 16, 17, but you can see there's still a ton of work to do, and there's no reason why these laws shouldn't be present. But there's also space for those states who have these laws to continue to move forward. So in Georgia, this is what we did. We actually are one of the states that had these 3 laws already present. And still, there were far too often stories of athletes who still died because nobody knew where the defibrillator was. Again, knowledge of the EAP was lacking. And so we pushed forward over the last year this bill, which was focused on EAP practice drills. This was our ACC state chapter working with other organizations. The 2 key tenets: ensuring that 2 EAP practice drills exist per academic calendar year for public schools, and extending AED access, not just high school, but all the way to kindergarten. And excited to say, actually, that this bill came into law in the spring of last year. So we did a press conference at the state capitol. This is our governor, Governor Brian Kemp. And it was a tremendous amount of effort across the board to get this across the finish line. So there's more work even for what Smart Hearts is trying to do as the first step for all of us to move forward. I'd encourage everybody to think about this. Not sure what the laws are in Virginia, but I would certainly look into that for those who have interest in this space, because I think there's a lot of work that can be done. So we've covered a lot in the space of the last 50 minutes. We talked about the epidemiology of sudden cardiac arrest and death in young athletes. Cases are uncommon. We don't know the exact incidence, but they occur. And it's important to kind of think about difference by, of course, age-dependent risk when you're going through the differential diagnosis. For the athlete who survives SCA or the symptomatic athlete, and for those athletes who have thought seriously about return to play, we should engage them. We should include a shared decision-making process with these athletes, with their family. The days of a paternalistic approach are truly over. Shifting to think about the pre-participation evaluation, the debate about screening ECGs are certainly far from over, probably will never end in the US. I think it's reasonable to think about, but again, you don't want to go through this carelessly or haphazardly. You got to think about who's doing this with you and the downstream resources. You have to ensure that there's equitable outcomes, because disparities are clearly present in the care of young athletes as they are across the board. And that has to be a focus of future research. In the end, it's about the EAP. We know that saves lives, has to be at the core in terms of the medical care afforded to competitive athletes. I mentioned ORCA just briefly before you open it to questions. Take a picture of this, check out that QR code. So this is meant for athletes, competitive athletes who have diagnosed cardiac conditions, who are going through the shared decision-making process. Even for those maybe who didn't. This is meant for athletes who have returned to play, those athletes who have not. It just recently opened up to high school athletes. So it's not just your collegiate athletes or pro athletes. Clearly, these are athletes across the country that could fulfill inclusion criteria. So if you take care of any of these individuals, you can check out the website, see if they would, if they fulfill that inclusion criteria. You can reach out to the co-investigators on one of them if there's any questions. But we really want to increase the summer. That's how we're going to be able to answer a lot of the questions and uncertainties that I mentioned. Thanks so much. Here's my email. I guess I should update to X handle. And then I'm asked to kind of put this up at the end again for your CME credit. So with that, thank you so much for your attention.
Thank you, Dr. Kim. It was very, very exciting talk. Definitely, we don't hear a lot about sports cardiology, and this is new and very relevant to practice. I would request any questions we can put in the chat box, but so far we haven't had any questions. In the meanwhile, I have a question about, you talked about the 8 pillars of shared decision making, and I'm just curious, like who leads the, like let's say a primary care physician who doesn't have enough understanding of like sports cardiology and or a general cardiologist, like or a fellow clinic, if we see a patient, who leads the team of shared decision making?
Boy, that is such a great question. One of the things that we also talk about, the question to ask up front when you have these cases arise is the humility part, and ask the question, should I be the one leading this? Now, certainly you've got the athlete and their family, so that's part of the triad. From a stakeholder standpoint, it's who on the team side is going to be relevant, the trainer, the team sports medicine physician. And then from a cardiology standpoint, it should be geared by the person who has the expertise. So obviously, if it's a primary arrhythmia, you're going to have an EP that's involved, whether or not they have pure sports cardiology expertise, they're going to have the expertise within the arrhythmia, as an example. If it's HCM, who's the HCM expert in the center? But you're right. I mean, I think one of the challenges is for the person who has the kind of the expert in terms of thinking about that condition from a cardiology side, the sports cardiologist, and it may require referral. You know, sports cardiology has outside the network to find that sports cardiologist nearby. It's a field, it's similar to cardio-oncology or cardio-obstetrics that we're all aware of. You don't have to send people up to Boston or Mayo Clinic or Emory. There is generally somebody nearby, almost any institution that is in the US, probably even in the same city. And so it's just a matter of reaching out to the person who you know may have that expert to say, hey, who is nearby? And so sometimes it does take a little bit of an effort to try to find that individual. I think over time, certainly as the field grows, you're going to have more individuals who are knowledgeable in this space that where you're not referring maybe to a city an hour away or whatnot. But it's important for us to advocate for that athlete as much as possible to find the right person who can help guide that decision and still be involved. It doesn't mean that that person, as who's developed that relationship with that athlete, is no longer involved. It's just trying to get all the right people in the room, which should still include that individual who's probably has that relationship already developed with the athlete as a part of the discussion. Another thing that I didn't emphasize is these are not, if you're getting into sports cardiology, I think sports cardiology is a field that for sure generates revenue. It is, anytime I counsel fellows about like, hey, I'm interested in sports cardiology. How do I do this? I always talk about like, hey, your institution is one that should advocate for this because by nature of tests that you order, referrals that you bring into subspecialists, it brings in revenue to the healthcare system. I mean, obviously, when you have a symptomatic athlete, there's a lot of tests that are involved, appropriate tests. But the point is that it's not one that doesn't bring in revenue. You see a lot of patients. I mean, all of these factors as it pertains to that. And but to get back to shared decision making, when you have these encounters, these are these are long meetings. They're numerous meetings, and sometimes they don't generate the highest RVUs up front. Because if you think this is a 15-minute meeting, you're mistaken. These are at least these are several hours, but spread out over time because you have to go over numerous things. But they're really rewarding as well. And again, it is an important part of the process.
Thank you. There's another question here who said by Ramesh, what does the pathway look like for trainees interested in career in sports cardiology? What advice would you give to those pursuing the field?
Oh yeah, that's kind of a nice segue question. There's a few things. Now, there's some trainees who are lucky and they're at an institution where there is somebody who is kind of a sports cardiologist. Now, if not, there's always going to be somebody probably who sees more athletes than not. And probably if you don't have a sports cardiology center, it's going to be somebody who takes care of cardiomyopathies because that's kind of a funnel, right? Like before sports cardiology existed, probably the HCM physician would be seeing a lot of these individuals. If you don't have that, there's ways to get involved nationally. So even if you do have that, you want to become a member of the ACC section, our sports and exercise cardiology section, because that's a way to get a lot of insight into educational materials. It's a way to know about where the national meetings are. We always have sports cardiology sessions at ACC. Every year, we actually have a dedicated sports cardiology meeting. So it's in DC. So it's actually not too far from you guys, relatively speaking. It's called the Care of the Athletic Heart Meeting. And I can tell you right now, it'll be in June of this year. So you look for that. But through the section, there's different webinars. There's links. There's a acc.org that we have where people are writing pieces, cases, et cetera. So you can start honing in on your knowledge about the space. It's a smaller field as it pertains to experts. So going to these meetings is a chance to meet experts in the field and to ask these same questions. Sure, it is a challenge if you don't have that person where you can actually see athletes regularly or shadow a clinic. Sure, it can be a challenge, but maybe you can start thinking about an away rotation or something like that where you can potentially find somebody out there and kind of go to clinic with them or nearby. Potentially, if it's like I've had folks drive to Atlanta. It's a little bit challenging at Emory to get away rotations, but I've certainly had interested trainees who will drive down and shadow a clinic with me, like every now, like maybe a couple times in a month that they've got an elective month, just because they want that experience. And so a lot of it is definitely a lot of kind of on my own, like how am I going to do this to build this? But there are ways, even if you don't have that individual, that expert at your center, that's the go-to resource to try to get that exposure and interest. And it will continue to get easier. I mean, imagine where I was when this field didn't exist. I was lucky because my mentor, who happened to be Aaron Baggish, I mean, I was at MGH. But 15 years ago or so, when I was in the middle of my training, it was really hard. Now it's easier, I would say. It's definitely doable. And we have so many younger junior faculty who are involved in the space that the number of evolving experts is growing. And 10 years from now, it'll even be easier to continue to gain that experience. Great
Thank you.
question.
Thank you. Maybe we can take one more questions about to be 8:30. It's question one of our fellows, Arun, saying, is there any role for imaging modalities to screen athletes to predict sudden cardiac death? And also, are there any predictive models to identify athletes that may encounter sudden cardiac death?
So a lot of that is going to be based on the disease process, right? So certainly, like we'll just use HCM. We know the risk stratification for ICD, number one. Many of you, and I haven't read the study myself, but I think there was just a study that came out yesterday or so in JAMA Cardiology about SCAR and MRI and kind of the higher risk. And so, as an example, if I have an athlete who has a lot of SCAR with HCM, actually just had one of these. Um, we know about scar burden in terms of thinking about ICD, but clearly if you have more than just a ditzeless scar, we talk 10, 15%, but maybe nothing else, that's still a risk factor when you think about competitive sport. And that has to be kind of qualitatively introduced in that shared decision-making process for the athlete to understand, for the organization, the sports team to understand as you kind of think about not only kind of sports eligibility, but how you're going to track that individual and clearly the focus on the EAP. So there's kind of that nuanced part about thinking of the disease process and what other risk factors could be considered. I mean, we do a ton of risk stratification. It's not just the imaging, it's exercising. You're looking for exercise-induced arrhythmias, exercise-induced ectopy, ambulatory rhythm monitoring as well, looking for these things and putting it all together to come up with kind of a risk calculus. For ACM, obviously you're thinking of genetic testing. Are they PKP2 or not as you kind of go through the process, or just in general, genetic testing could be something to consider as well. Overall, as a predictive model, there is not one to where just in general. I mean, again, I think you're just kind of thinking as you would anybody else about looking for potential clues that could go down a road for a specific diagnosis. I'll give one example. You have an abnormal ECG, abnormal T wave inversions, suggestive of hypertrophic cardiomyopathy, but you do imaging, including an MRI. Wall thickness is totally normal, no scar. They just have an abnormal ECG, but a structurally normal heart. That's not a risk factor for them. That just means that they should go back to playing sport. But then every year we need to do annual surveillance because we know about 5 to 7% of the time, these abnormal ECGs with these T wave inversions can evolve to a potential cardiomyopathy. So again, it's just that understanding of what needs to be part of that longitudinal surveillance as well.
Thank you, Dr.
Great
Kim.
question.
We are already at 8:32, so I would like to thank Dr. Kim for your time and also the audience for the attending the grand round. And we share the slide. Yeah, this will be the slide, so you can text here this number to get the CME credit.
Thanks so much, guys. I really appreciate it. And any